Um, so good afternoon. This is our third Learning Collaborative session on care coordination models for elders with diabetes and other chronic conditions. And today, if I can actually move my slides, we'll also send out the slides as well. Today, actually going to focus more specifically, I should say last time we focused on care management, overall care management, and this week we're going to talk about care coordination for older adults, specifically diabetes, and explore elements of care coordination in this population. Patient-centered care and care coordination of patients with complex conditions has, there's been a lot of increased attention from different organizations, particularly around quality. So some of the national quality organizations, such as the Agency for Healthcare Research and Quality, or AHRQ, and the National Quality Forum. And because of this, care coordination really has been embraced under quality healthcare. I think they've even identified it as a cornerstone of quality healthcare. So today, we'll just broadly cover the impact of fragmented care on healthcare outcomes and costs, and also thinking about a fragmented care case in an older adult. Understand the goal of care coordination in older adults with diabetes, as well as the essential elements of care coordination, and then talk about and share models of care coordination in care coordination in general, as well as in older adults with diabetes. So I know that early in the Learning Collaborative we've talked about chronic care conditions and defined what chronic condition is and the care necessary. And chronic conditions oftentimes require ongoing adjustments. It's opposed to acute conditions. It's always something that providers have to manage and check in on, and often can involve not just the provider, but also other interactions with the healthcare system. We know that a lot of people are impacted by chronic conditions, and that more than half of the U.S. population live with a chronic condition, and we know that also this impacts older adults as well. And that will also see an increase in those living with multiple chronic conditions, and that really requires a chronic disease management process or approach. So, excuse me, many managed care and integrated delivery systems have taken a great interest in correcting deficiencies in what we've seen under current management of diseases, particularly multiple complex diseases such as diabetes, heart disease, and depression, things that impact older adults. And certainly a lot of healthcare systems have been really actively exploring how to manage their patients' chronic diseases. According to the we used to be the Group Health McCall Institute, there's they had identified potential deficits in chronic disease management. And these all kind of flow into one another. They've talked about rush practitioners who may not be following established practice guidelines because the session times keep getting shorter and shorter. And this can be a huge impact, particularly for older adults, where they may have not only a chronic disease, but they may have multiple chronic diseases that require ongoing ongoing checks, and also require different healthcare providers as well as other outside resources to manage their disease. That follows with care coordination that might be lacking, and if there's a lack of care coordination, then there may be no prescribed plan of action, or a plan of action that is then followed up on. And so follow-up with a plan may be minimal or non-existent, and that without the follow-up, it's unlikely that you can ensure the best outcomes for the patient. And oftentimes that will leave patients to their own devices, where they are trying to self-manage their disease without really understanding how they can self-manage, and they may make choices that might not be in their best interest, their best health interest, as well as other needs that they might have. A report from the Network for Excellence in Health Innovation says that improving care coordination and increasing particularly medication adherence in patients with chronic diseases are key to providing better care for patients with diabetes. And that achieving the best results with medications for diabetic patients requires thousands of steps every year, not only from patients, but also from clinicians and other individuals in the healthcare sector. And so the constant checking in with managing that chronic disease. And so success really requires a lot of coordination and support, and oftentimes that's not the patient experience, because they may experience fragmented and uncoordinated care. An example of this is patients who have type 2 diabetes. They have to manage their blood sugar, they have to manage their diet, they have to be active in order to keep their disease in check. And oftentimes they may have other health conditions where they're taking multiple medications. They also might be taking multiple medications for their diabetes. And if we layer on other things in terms of being older and some of the cognitive deficits and potentially even mental health issues, it doesn't make it easy for them to navigate a very complex system that they can cope with in terms of managing their chronic disease. And that can result in fragmented care that can cost upwards of billions of dollars. So I think that we had talked about this before in terms of managing multiple chronic conditions really requires a transformation in health care, and that it's one that can be more proactively focused and focused on keeping a person healthy, and primary care practices and safety net practices play an important role in the frontline management of chronic disease, as you know. This is the chronic care model that was developed by the McCall Institute that I think a lot of people are are aware of. And the McCall Center for Healthcare Innovation actually has an online resource for the primary care team called the Primary Care Team Guide that gives practices access and information to practical advice, case studies, and other resources that help practices become high-functioning teams and to improve their patients' care. And so it's something if people are interested in, they can check that out. So when we look at fragmented care, oftentimes it can be really helpful to illustrate a case. And this is a case that appears on the improvingchroniccare.org site. And it's a 58-year-old grandmother with a 15-year history of type 2 diabetes complicated by elevated blood pressure and recurrent episodes of major depression. She has a BMI of 37 and has struggled with weight control since she was a young adult. And on her recent visit to her primary care doctor for progressive fatigue and other depressive symptoms, she was found to have a hemoglobin A1C level of greater than 9%, close to 10%. A blood pressure of 190 over 106, and a PHQ depression screening score suggesting that she had major depression, even though she is taking an SSRI. And so her PCP postponed adjusting both her hypoglycemic and antihypertensive drug doses until her depression was better under control, and referred her to a mental health center to review and update her depression treatment. She had some difficulty in getting an appointment at the center, and then ended up seeing a mental health provider that she had never seen before. When she was at the visit at the mental health center, her blood pressure again was elevated at 220 over 124, and she complained of a headache as well as her tiredness. And so the psychiatrist, who had never seen her before, had no information about her, became alarmed about her blood pressure and her headache and had sent her to the ER. And so at the ER, the physician told her blood pressure medicine was inadequate. She needed new, more powerful medications, and she was given prescriptions for 2 new antihypertensive medications. Because she wasn't clear what she was supposed to do with those medications, along with her current medications, or the doctor that she needed to check in with about it, she ended up taking all of the medications. And so a week later, she had an episode. 911 was called, and she was taken to the nearest hospital where she had some neurological deficits and admitted with a possible stroke. And so they adjusted her medications in the hospital, her blood pressure stabilized, and the deficits cleared, and she was sent home again with an appointment to the mental health center to have her depression, which was worsening, managed. When she was at home, she was becoming increasingly depressed, forgetful, dysfunctional. She, again, her fatigue was worsening, and so she really didn't have the energy to reach out to the mental health center to make an appointment. She became non-compliant with her medications, and several weeks later was found by her daughter to be bedridden and hemiparetic. And her daughter then had her readmitted to the hospital and she was readmitted with a completed stroke. And so when her PCP had found out from her daughter what had happened, they were dismayed. He was unaware of any events that had happened to her from the last visit that she had with him, and her daughter also was stunned and angered by his ignorance. Although this is a case, and this is a pretty drastic case, it illustrates what can happen with fragmented care as people in the past have moved from provider to different provider, where there's no transition or care coordination between the providers. And so what we've started to look at, what people have started really putting an effort into is care coordination. And so the care coordination is a deliberate organization of patient care activities between two or more participants involved in a patient's care to facilitate the appropriate delivery of healthcare services. And in looking at this definition, things that are highlighted, really going from one to the other, is the care, and that care goes all the way through the activities to ensure that the patient is being treated in the best possible way. So the overall goal of care coordination is to help ensure that the needs and preferences of each patient and the family and caregivers are acknowledged and accounted for during the development of a comprehensive plan of care across providers, services, and settings. And this is really imperative, particularly with older adults, and as they are getting older, and the patient may be bringing in family and caregivers into their healthcare needs. And so making sure that everyone understands what the plan is, who's involved in the plan, what their respective roles are, and all the logistics around it is very important. So according to the Agency for Healthcare Research and Quality, they've identified key elements in care coordination. That there should be a comprehensive needs assessment, needs assessment of the patient, as well as the healthcare organization, healthcare center, in terms of the services that they have available, the key partners, and identifying either community resources or specialists that can be brought into the comprehensive care plan. It also requires individualized care planning, because every patient may come with their own unique set of circumstances, not only in terms of the chronic disease, but also the multiple chronic diseases that they have, as well as what their individual needs are beyond their health issues. It also requires access to needed services and equipment, which is why the comprehensive needs assessment can be very helpful in understanding what is available and where they might need to fill the gaps. And then the last key element is focused on communication and monitoring of the comprehensive care plan. So in care coordination, one of the issues in terms of implementation, adoption and implementation of, is that there can be several difficult aspects of it. And so we often ask, well, why is care coordination so difficult? And there's several reasons. Accountability for the process is shared, which can often contribute to ambiguity as to who is responsible for making it work well. Oftentimes, many primary care physicians no longer have personal relationships with consultants and hospitals that makes communication easier. And so they may not know who to reach out to. Additionally, with care coordination, there's added time and effort that's required to achieve an effective referral or consultation or transition that may not be reimbursable, and so that may also lead to difficulties in implementation. And lastly, primary care practices or centers may not have dedicated personnel or information infrastructure to coordinate care effectively. And certainly there have been developments in this in terms of trying to find either existing personnel who could fill that role or to bring additional staff on. So kind of looking back to the AHRQ and the key elements that they had suggested, I think that one of the things that comes out with respect to care coordination as a primary goal is a high-quality referral or transition. And a referral occurs when a patient requires additional specialized care by a medical consultant or even a community agency. And a transition is when a patient's overall care might be transferred between different groups, such as from primary care to hospital or hospital back from the primary care. So when we think about high-quality referrals and or transitions, what are some of the defining elements that are necessary? And patient referrals and transitions should meet the 6 Institute of Medicine aims of high-quality healthcare. And so from that perspective, they should be timely in that patients receive needed transitions and consultative services without unnecessary delays. They should be safe in that referrals and transitions are planned and managed to prevent harm to patients from medical or administrative errors. They should be effective in that referrals and transitions are based on scientific knowledge and executed to maximize their benefit. They also should be responsive to patient and family needs and preferences, so they should be patient-centered. And they should be limited to those that are likely to benefit the patients, as well as to avoid unnecessary duplication of services. So there should be some efficiency in the referral and transition. And then lastly, the referral and transition should be consistent for all patients, and that the availability and the quality does not vary by the personal characteristics of the patient, so that equity is achieved. This is an example of the McCall Institute for Healthcare Innovations care coordination model. This is based on a patient-centered medical home, and you can see how with the model, how they, under the patient-centered medical home, you have accountability and patient support, and that is linked with relationships and agreements and connectivity, and the patient-centered medical home is linked to community agencies, hospitals, and ERs, as well as the medical specialists, and that using a care coordination model can result in high-quality referrals and transitions for providers and patients. And so using this model, as we said, the goal of care coordination is high-quality referrals and transitions. And among the elements for successful referrals and transitions is assuming accountability, providing patient support, building relationships and agreements among providers, including community agencies, that can lead to shared expectations for communication and care, and developing connectivity either through electronic or other information pathways that can encourage timely and effective information flow between providers, between primary care providers, specialists, as well as community agencies. So practices wanting to improve the coordination of their care should consider making changes to practice systems and processes consistent with those 4 elements. And these 4 areas represent high-level, what they refer to as change concepts, which the Institute for Healthcare Improvement defines as general ideas that can be adapted to make specific changes that lead to improvement in many processes and clinical areas. And in aggregate, they describe a change package for better care coordination. So in looking at this change package, not only do we have under the change coordination model, not only do we have the change concept, but we also have key changes, and following from those key changes, we have activities. And so they've identified under the care coordination model 6 key changes that apply to each change concept, and then the specific activities in making the key change. And so, for example, under patient support, the key change is that a practice team is created to facilitate support of patients and their families. So, for example, a practice team would be created to facilitate support of diabetic patients and their families. And some of the activities that that would fall under there would be training either current or new staff to coordinate referrals and transitions to care, and that they would also be trained in patient-centered communication. So, for example, motivational interviewing or problem solving. And so what some folks have done is they've developed a new staff member. Some of them refer to as healthcare coordinators or health navigators. Some are generalist health navigators, and some, particularly for groups that have large diabetic populations, they may have a diabetes health navigator who can coordinate referrals and transitions and understands the resources available and knows how to coordinate patients' care to those with those different providers and those different resources. Additionally, some other activities under patient support is assessing patients' needs in all areas. Additionally, identifying and addressing patient barriers to referrals and transitions. So what are some of the barriers that the patient might have with respect to either making a referral or following a transition? And then also, with respect to patient support, the need to follow up on any referral transition so that there's a feedback loop on that referral or transition, and that that loop is closed with respect to the care that was provided or given, and where the patient was at after that referral was made. So as we think about coordinated care, we can look at this on the other end of the spectrum, I should say. We can look at another older, or a similar older adult case where the care has been coordinated. And as you'll see in the slide, in terms of the history and the initial PCP visit, it's the same as the fragmented care case that we had discussed previously, or had shown previously. And in the slide, you'll see that the green highlight is where there's been a change. And so in this example, we have an older adult woman, again, who has a decade-plus history of type 2 diabetes. It's complicated by high blood pressure, and she also has recurrent episodes of major depression. She has a high BMI, and she has struggled with weight since she was a young adult. She's also found to have an A1C level at around 9%, elevated blood pressure, and the depression screening tool shows some evidence, suggests some evidence of minor depression. Her PCP again postpones adjusting her diabetes and blood pressure meds, and she's referred to a mental health facility. In this coordinated care example, one of the significant changes is that the PCP who had recognized that she had patients who had depression, had previously engaged with this mental health center, and had developed a relationship with one of the providers and agreed to refer to this particular provider and to provide them with access to an e-referral system. And so the mental health referral was made because the PCP insisted that the patient make the appointment with the referral coordinator's assistance before leaving the health center. So once the patient left and the appointment had been made, she did miss the appointment because of a family illness. Because there was an e-referral system, it noted the missed appointment, and the referral coordinator called to reschedule. So when the patient was finally at the mental health visit, the mental health provider had her clinical information available, and the provider adjusted the depression meds, but noted elevated blood pressure, similar to the fragmented case. The patient also complained of headache and fatigue. The difference in the coordinated care case, however, is that the mental health provider arranged for her to be seen by her PCP later that day. And so when she arrived later in the afternoon for her PCP visit, her PCP adjusted her blood pressure meds. And when she was sent home, the referral coordinator contacted her and suggested that the blood pressure be checked by EMTs at the neighborhood fire station every other day. And this is something that the patient had complied with. And over time, she began feeling less depressed, and her blood pressure came down to the target level. And so in this case, you can see where the PCP had previously set up a referral system so that when she had patients who had multiple chronic diseases, and particularly with diabetes, and as well as a mental health issue, that a referral system was already in place. And so when it became time for a patient to be referred, the referral system kicked in. There was a dedicated staff member who assisted with coordinating that referral. It happened before the patient actually left the health center. And even though the patient missed the appointment, the system noted that and alerted the coordinator to call and and reschedule. Additionally, the coordinator also reached out to community agencies, in this case the EMTs at the neighborhood fire station, to connect the patient with their services so that when she was at home, she could also be monitored and was also given very specific instructions in terms of self-management. And by checking in and having those things, those other things managed, she was able to then get some of her chronic issues back on target and was able to manage much better than the case of the fragmented care. So just wanted to note, in looking at some other, integration and care management models, under the patient-centered medical home standards is a standard on care coordination and care transitions. And under that, there's several aspects in terms of test tracking and follow-up, referral tracking and follow-up, and coordinating care transitions. And in the standard, referral tracking and follow-up is something that they must pass. So referral tracking and follow-up, as we said previously in terms of one of the primary goals of care coordination is really the referral and transition process. So I wanted to give one example of care coordination. This is the Genesis Health System, and they have a program, the Genesis Health Works. And here they actually emphasize linking with community resources. They focus on coordinating care for all of their patients, not just diabetic patients, but all their patients for utilizing community resources, and it emphasizes making what they call an effective referral. And that is, they know the resources that are out there. They prepare the patient to utilize those resources. They follow up to ensure to check whether the patient has utilized the resource, and they address barriers to maybe missing that referral or preemptively addressing barriers to ensure that the patient engages with the referral. And so in their Genesis Health Works, they employ health navigators. And the health navigator is there to support the patients in self-care, as well as connecting with community resources to enhance self-management. And so this is just one example where their focus really is ensuring that there are appropriate community resources that their patients can connect to, in addition to the provider resources within their health system. So I just wanted to open up to some of the care coordination processes or models that you might be using in general, as well as if you have specific ones that you use for your diabetic patients, and also if you have some even more specific ones for your older adult diabetic patients, because we recognize particularly that the needs assessment aspect, the needs assessment element can be really important with the care coordination model, because you have to look at not only the what's available with respect to the health center and specialists in the area, in the community, and community resources, but what are the needs of the patients. And if you have patients who are older and may have cognitive issues, it might be different in terms of the care coordination process than if you have patients, very little, a very few number of patients that have cognitive issues. So I just wanted to ask about what care coordination processes or models that you may already have in place or are anticipating putting into place. And I know, Kelly, you said that this is something that you've have just started putting into place or exploring how to best implement what you would like to do.
Right. We have so we have several different locations, and each of our locations really works with a very different population. So each site has been trying out different methods of trying to coordinate care specifically around diabetes. Right now, our agency has put together a diabetes work group for us all to get together and just kind of uniform what our approach will be. We also are, I actually just signed the paperwork to hire our first diabetes-specific case manager. So they're going to be starting at the beginning of next month.
Oh, fantastic.
So, yeah, we're really excited. So what we decided to do is we have kind of a 3-tier case management system. So we're going to be doing a like a linkage to care tier of services for people that are newly diagnosed with diabetes to provide support and education and make sure that they have all the tools they need to be able to self-manage. We have 2 other tiers depending on what the diabetes is looking like. So if it's we have a really intensive model for kind of like that case study that you presented today for folks that really need a lot of support. So that we will be implementing. Right now, it really, like I said, it varies depending on the site. At one of our locations, we do have a diabetes educator that meets with all of the patients that come through that clinic that have diabetes. But yeah, it just really varies as to the level of care coordination right now.
So in terms of the intensive model, it sounds like that's as you said, similar to the case that was presented. So people who have multiple chronic conditions besides beyond diabetes that where the coordination is really complex.
Right. So we're looking at as general eligibility, it's going to be people that have an A1C above 9, and we're prioritizing populations that have either fallen out of care, have not had a medical appointment in the last 6 months, who have reported non-adherence to medications, and we have a couple other different criteria just to really make sure that we're able to get to those really vulnerable populations that really need that support, and especially around navigating the systems. And I know one of the clinics has reported recently having a lot of struggles with some of the managed care companies in Illinois with changing the medications a lot in the process and what is the recommended and what needs prior approval, and really having challenges navigating that. That's one of the big things that we think the case managers are really going to be assisting with.
Yeah, so that speaks to that in terms of some of the table that I had talked about, the key activities and understanding the needs of the patients, not only the clinical needs, but as you said, the financial and logistical needs. And so, as you know, oftentimes the healthcare financial aspect is very complex and not understandable by patients, sometimes not understandable by us, by the way they do things, and what's allowable, what's not allowable, and having somebody to translate that and connect people and is really important. So that's really interesting that you're doing that, and would love to hear how that's working for your intensive model. So it seems like for the intensive model that you really focused on people who, well, based on the Bureau of Primary Healthcare and HRSA in general, that they want to bring down the A1C to less than 9%. But then also this issue of self-management and along with medication adherence, because that can be so problematic for patients.
Mm-hmm.
Do you see this in your older adults more often, or does it kind of fall across the age spectrum with your diabetic patients?
When we've looked at the data, I haven't really seen any real patterns in regards to age. Mm. We've seen more around the racial demographics of our populations, and also the geography. Just in Chicago, it varies widely. We do recently have a partnership. We are providing medical care at a site for one of the mental health providers in Chicago, which is really exciting. And I'm waiting to get the actual data, but just in speaking with the practice manager of that site, they're estimating that their diabetes rate for their patients is between 75% and 90%.
Wow.
So I don't know. I know sometimes some of the medications for mental health can impact diabetes. So I don't know if that's a piece of it, or why that rate is so high in that population. And again, I'm waiting for like the actual number, so it might not be at that level, but that's what they're seeing, just kind of observationally. So population that we're really going to focus on as well.
That's really interesting, and then and it kind of the case speaks to what you had just mentioned in terms of some of these comorbid conditions or multiple conditions that if one goes unchecked, it can elevate the others as well, and just become a problem. So they so you said they're providing medical care at the mental health provider's office?
Right. We have clinic space in their building, and so they. In the end, will be a full-time clinic. Right now, they're open 3 days a week, and so any of the patients of the mental health facility can get medical care through Howard Brown at that site. So that way they don't have to travel anywhere else.
So what type of care coordination system do you have between, like, do you have an e-referral or kind of in-person referral? How do you manage the coordination between the two?
That partnership is really new, and I just engaged with them actually this last week, so I don't have a ton of their details yet. But what we've done at other sites, there's a couple other community-based agencies that we became medical partners for, and we're using our EMR at their sites to communicate.
Okay.
So I'm not sure if they do that with the mental health agency, but I know with the community-based ones, that's what we've done thus far.
Oh, okay, okay. So with the community-based agencies that you've been doing care coordination with, you can communicate with through the EMR.
Right.
Oh, fantastic. That's excellent. So I'm actually realizing I have a ton of other questions that I can definitely ask you, and but I'm realizing that our time is over, and so so glad that you're able to join us today. And for the last session, we wanted to check in because we had to reschedule the previous sessions. Wanted to see if you would be available for next Thursday at the same time, because we'll need to close out our sessions, or they'd like us to close out our sessions by the end of June. And so I just wanted to see if the Thursday at the same time would work, or if there's even a better day and time.
It would be possible to do Wednesday. That would work better for me. I'm going to be at a conference on Thursday, so I could always do what I did last time and just step away for the time. But if folks were available for Wednesday, that would work really well for me.
Okay. Okay. So we'll take a look, and then we'll definitely send out an announcement about it within the day, and then you can put it on your calendar. So that would be fantastic.
Sounds good.
Great. Thank you so much, and have a good rest of the day.
Yes, you as well. Thank you.
All right. Bye-bye.
All right. Bye-bye.